Thank you all for attending our first annual NOCC Midwest Region Symposium. We are here to bring you information about ovarian cancer today. This is our partnership with City of Hope, formerly Cancer Treatment Centers of America. I've enjoyed a long relationship partnering with cancer treatment centers for a number of years. I've been here for 12 years. My name is Karen Young. I am the Senior Regional Manager for the Midwest for NOCC. Over a decade, I've been here, and almost a decade, I've partnered with CTCA and now City of Hope. So we are very excited for you all to be here today to deliver quality information to you about hot topics in ovarian cancer this morning. Wow. So I want to introduce, and I'm going to switch over to speaker, go back to speaker mode, and introduce our guest speaker today. Our keynote speaker is Dr. Ruchi Garg, who serves as the Enterprise Chair of Gynecologic Oncology at City of Hope. Dr. Garg brings more than 15 years of oncology experience to City of Hope, joining the National Cancer Care Network in May of 2021. She treats patients at the hospital near Atlanta, Georgia. So Dr. Garg, welcome. Thank you so much for joining us today. And we are so excited to hear what you have to educate us about today.
Good morning, everyone. Thank you so much for being here early morning on a Saturday. I just already had a full morning. I had a T-ball event, 4-year-old toddler event that I just came from. And I'm ready to talk to you about ovarian cancer. We're going to talk about maintenance, surveillance, and survivorship. Please feel free to interrupt, ask questions in the middle so you don't forget your questions. And, we can make it more of a discussion point, and, get through some of the topics that I thought you guys might be interested in. I chose the topic thinking that, most of the patients who join NOCC tend to be towards the middle or end of their initial treatment or maybe further along. So these topics may be more applicable to you. Again, my name is Ruchi Garg, and I'm a gynecologic oncologist at City of Hope in Atlanta. And there we go. We're going to briefly just jump into some ovarian cancer statistics. Ovarian cancer is actually the second most common gynecologic malignancy in developed countries like United States. And it's the third most common gynecologic malignancy in developing countries. The first most common is uterine cancer in both developed and developing countries. And then in developing countries, the first one in developing countries is cervical cancer, and then uterine, and then ovarian cancer. What's important about this statistic is that it is associated with the #1 death rate in amongst gynecologic malignancies, and which basically tells us that there's a lot of work that we still need to do. 95% of of ovarian cancers are epithelial type. And the reason I'm sort of getting into this little nitty gritty is because you'll hear that every now and then, and patients, not all ovarian cancers are the same. The other types are germ cell tumors and sex cord stromal tumors. And I basically have a picture of this, of an ovary, and the outer lining, the surface of the ovary is what is called as epithelium. And that is where most of the ovarian cancers arise from. And those are the ones that we really sort of hear about all the time, the most aggressive type. The other two types, so the germ cell tumors arise in the egg, egg cells basically, and then the stromal tumors arise in the rest of the ovarian tissue. And those actually tend to be more chemosensitive. There's better response rate. Well, germ cell tends to be more chemosensitive, and the stromal cell tumors tend to be just slower growth, present at an early stage. So those two cancer types have better survival and better prognosis. And for today's purpose, we're going to talk just about the high-grade serous ovarian cancers that arise from the epithelium, okay, the outer lining. So high-grade serous ovarian carcinomas are the most common ovarian cancers. They're closely related to fallopian tubes and the peritoneum. Peritoneum is the lining of the abdominal wall, in the inside lining, and it covers the whole abdominal surface, and it also covers multiple organs inside the belly. So what's been shown is that the embryologic origin for these cells is the same, and that's why they're all sort of lumped together and treated in a similar manner. They behave, clinically the same as well, or similar. There's actually a latest theory that perhaps all of these cancers actually originate in the fallopian tubes and then spread from there. This is how we stage ovarian cancer. In general, stage 1 is limited to one ovary or both ovaries. Stage 2 cancer is limited to the pelvis area only. Stage 3 is any spread inside the abdomen that could include lymph nodes in the abdomen or the surface of the organs in the abdomen, including intestines or liver and things like that. However, stage 4 is intrinsic lesion in these organs. So if it goes deeper into the liver, that's stage 4. If it goes deeper into the spleen, that's stage 4. If it goes into lungs, if it spreads outside the abdomen, that's considered to be stage 4 disease. Unfortunately, majority of the ovarian cancers, about 75% of women, are diagnosed at stage 3 or 4 disease. So we're going to jump right into overall sort of initial management. So because the patients are diagnosed at advanced stage, there are different treatment approaches. Most commonly, the initial management includes primary surgical cytoreduction, which means that we plan or we intend to do a debulking surgery where we are going into the belly and we're removing the main cancer and the associated organs and at-risk organs, as well as we're staging the cancer where, like, the most common sites where the cancer can go, which includes taking out the omentum, taking some biopsies, lining the peritoneum, but it can also include taking out some lymph nodes as needed, depending on how large they are, or if we need to do, for staging purposes. That's the most common goal and intent, and that's the primary management. However, there are, and more we have identified that there are patients who are not good candidates for surgery, for initial surgery. And that's usually due to the location of the cancer. Sometimes the cancer can be in sites where we just can't safely remove it, and or it's just a huge volume of the cancer where it's just not feasible to remove that many organs or that many parts from inside, or have put a patient through such a prolonged surgery that would be necessary to be able to get all of that cancer out. The goal of these surgeries is to remove all visible cancer. So that's always a thought in the back of our minds, that are we going to be able to go in and remove all sites of cancer? The other things another thing that actually presents a problem is if the patient has a lot of comorbidities, meaning if they have, a lot of heart-related issues, or their diabetes is really uncontrolled, or they've had previous stroke, something like that. So if they've had a lot of medical problems, we worry that they're not going to be able to sustain a large, intense surgery that requires a lot of body's reserve to recover from. And so at that point, it becomes a clinical judgment, and whether we should be giving such patients chemotherapy first and then considering or taking them back for surgery. There have been many studies that have looked at that aspect and have actually shown that in that particular patient population, the survival and prognosis is no different by giving them chemotherapy, before the surgery, essentially. So that's there's been a lot of data about that, and so that's reassuring. After the big surgeries, after the goal is always to start chemotherapy or treatment, especially in advanced stage cancer patients, within 2 to 4 weeks from the surgery. So we always, and even though the patients are recovering during that time, we still want them to get on chemotherapy, because now that we have gained the benefit of doing a good surgery and reducing the volume of the cancer, we know from our training, from research, that the smaller the cancer cells, the better the response to chemotherapy. So we really want to get to and attack those cancer cells as soon as we safely can from the surgery. And the goal is usually within 2 to 4 weeks. There is some limited data that does suggest that the delay by over a month in starting chemotherapy can lead to poorer outcome. But we're not sure whether that is due to the delay itself, or is it because of the clinical factors that led to the delay. So usually the delay would happen if the patient was, too sick from the surgery, or there was a surgical complication, or there was delayed healing, or, or the performance status of the patient was just not strong enough where they could sustain a chemotherapy and its toxicities. So we're not quite sure, where the catch-22, what's the beginning of the catch-22. So nonetheless, we know that the patients that we end up having to delay the start of chemotherapy do a little, have a worse outcome than those who don't. The standard treatment for women who are diagnosed with ovarian cancer or fallopian tube cancer, or peritoneal cancer, is to do chemotherapy with platinum agent along with taxane. Most common agents that we utilize are carboplatin and paclitaxel. You'll hear a lot of your medical team call it carbotaxol. So that's really sort of the standard chemotherapy that's utilized, regimen that's utilized. For women who undergo optimally reduced surgery, so what that means is, again, as I said earlier, the goal is to remove all visible cancer. And if we're not able to do that, the next best goal is to at least get the disease less than 1 centimeter at each different sites, basically. And those patients respond best to IV chemotherapy alone, or intravenous chemotherapy along with intraperitoneal chemotherapy. So in that scenario, what we do is we actually put a port in the patient's belly with a tubing that goes inside, and then we inject chemotherapy every few weeks through that port. And it's a combination of intraperitoneal chemotherapy and intravenous chemotherapy. So we're basically giving the chemotherapy directly at the place where the cancer has been. And that I would say at this point, you'll see a variety of treatment patterns in that, and we really have left it, the Society of GYN Oncology has really sort of left it up to the judgment call of the physicians as to what the patient is going to do, their patient is going to do best with. Another type of chemotherapy option is heated intraperitoneal chemotherapy. And that has mainly been utilized in patients who have received upfront chemotherapy and then now are undergoing interval debulking. So now most commonly patients will get 2 to 4 cycles of chemotherapy first in the upfront setting. And then when we determine that they're at a point where the volume of disease is low enough, or the performance status is improved enough that the patient can undergo a big surgery, that is the point we take them for surgery. And again, the goal is to optimally cytoreduce the cancer And then at that point, we can utilize intraperitoneal chemotherapy, again, with the mindset that we're giving the chemotherapy directly at the site. And the difference between this heated intraperitoneal chemotherapy is that this happens at the time of the surgery, and it's a one-time shot. Basically, right after we've done or removed the cancer cells, we put the tubing in, and we deliver the heated chemotherapy right there, and it gets basically it sits there for about an hour or so, and then that's been shown to improve survival in patients in this patient population. If the patients go through suboptimally reduced disease, meaning if we're not able to, we go in surgically and there are surprises. So, the CAT scan wasn't accurate enough, or, it didn't show all the disease. Because one of the things that patients, everybody needs to realize is that the CAT scans and all of these imaging that we utilize, they're only about 80 to 85% sensitive, meaning they're about 15 to 20% times that they miss things. So when we go in the belly, that's when we can see whether or not we can actually remove all part. That's when we can truly tell whether or not we can remove all visible disease. And sometimes we just can't. So I would say on average, most of us are successful in doing so about 70% of the time. And then 30% of the times it's not feasible. So when we go in and we're not able to remove all visible cancer, and we are not able to decrease the volume down to less than 1 centimeter individual sites, then that is called suboptimally reduced disease. And then these patients are actually not candidates for intraperitoneal chemotherapy, either intraoperatively or subsequently. And we end up giving them intravenous chemotherapy alone subsequently. So I'm going to move on to what we really sort of want to get into. The meat of the matter is the maintenance therapy. So what's next? Patients we know that ovarian cancer is epithelial ovarian cancers are aggressive cancers. We know that advanced stage epithelial ovarian cancer patients have about 75% chance that even after they get all of this upfront therapy and do really well, and there's no visible disease and everything's sort of gone perfect, they still have about 75% chance that the cancer can come back. So we have, the thinking has changed about, should we just, in the past, when I started in this field 20 years ago, the thought process was never to give maintenance therapy because we just didn't think it made a difference in survival. It may delay the recurrence time, but it didn't make a difference in survival, because at that time we used to use only chemotherapy for maintenance. So that thought process was really rarely utilized. However, in the last 7 years or so, the thought process has completely changed based on the latest data and new drugs that have come out. One particular area where that has changed is in BRCA mutated patients. So BRCA mutation, that is a germline genetic mutation that can occur in patients. There are 2 big types that we talk about, the BRCA1 gene and BRCA2 gene. And when this mutation occurs, these women are at higher risk. These patients are at higher risk for breast cancer. They have about a 60 to 85% lifetime risk of breast cancer, but they also have a significantly elevated risk of ovarian cancer. So ovarian cancer in general population, the risk of ovarian cancer is about 1.3%. If you have a first degree family member who has ovarian cancer, but the genetic mutation has not been diagnosed in them, then the risk of ovarian cancer goes up to about 3%. So it just basically doubles. But in patients who have BRCA1 mutation, the risk goes up to 40 to 60%. And in patients who have BRCA2 mutations, the risk goes to 12 to 27%. So you can just automatically see they have a much higher risk of developing cancers. And what's been great, the latest development is that these patients who have this mutation and respond to the platinum therapy upfront actually do really well if we offer them a maintenance with an oral drug called poly-ADP ribose polymerase inhibitor, which is PARP inhibitor. Okay. And we'll get more into the details. So that's that. This drug has been a game changer, basically, in our world. For the first time, there's been a dent made not just in the progression-free survival, but also the overall survival for women who are undergoing treatment for ovarian cancer. Another way to test for, that's done germline mutation. So we're looking at either the patient's saliva or blood test. But another way to determine BRCA mutation, so patients can have germline mutation, which gets passed on from generation to generation, or they can have somatic mutation, which is just a mutation in their tumor itself, in the cancer itself, and that doesn't translate into passing on from generation to generation always. So we send all ovarian cancer specimens for somatic testing, and we're looking for mutations both in the BRCA genes, but we are also looking for something called homologous repair deficiency or mutations in that pathway. And what we're looking for, and I'll get deeper into what those things mean. We're looking for the instability, genetic instability in the cancers, and those patients, again, respond well to PARP inhibitors. So specifically for homologous repair deficiency or deficient cancers, or HRD, as I'm going to call them from now on, this is when the genes that regulate a cell's repair pathway are damaged. So, our cells, so what are cancer cells? Cancer cells are our own cells that have basically gone haywire. They have made a mistake in how they control their growth. Our body has a self-check mechanism. So, our nose cells don't keep growing and we don't get a big, nose or things like that. So our body has a way of the cells to die, old cells to die and new cells to form. But when the old cells don't die and the new cells keep forming, that pretty much is like the very basic way to explain cancer. And there are genes and there are, self-regulating regulating mechanisms that control this pathway. So if the cells are unable to fix that damaged DNA, then those cells are more susceptible to this kind of treatment. And the great news is that about 50% of women with advanced ovarian cancer are actually HRD positive, which basically means that they are very sensitive to chemotherapy and cancer and these kind of treatments. So again, diving deeper into the HRD. So HRD is basically any so BRCA mutations, so BRCA mutations are actually also in the pathway of HRD. And then any kind of genetic mutations, some of the genetic mutations and more chromosomal changes in the cells can lead to homologous recombinant deficiency, and basically, again, inability to repair the DNA and causing genomic instability. And this basically shows that about 25 to 30% of the patients from the HRD group, so half of those patients are from BRCA, and then another half are from non-BRCA mutated pathways. And then about 50% of the patients are HRD negative. And we'll get a little bit deeper into that as well. So there have been several trials that have been really sort of game changers in the last few years about these PARP inhibitors and maintenance therapy. So one trial was on niraparib, and the brand name for that is Zejula, that you've probably heard about. One is payola trial where they utilized olaparib, or Lynparza is the brand name, along with bevacizumab, or you'll hear different sort of brands with that, but the most common brand that you'll hear is Avastin. And another is veliparib, and that's not actually, it's another PARP inhibitor, but it's actually not approved, FDA approved in US yet. And then these are older trials that were done about maintenance with bevacizumab in ovarian cancer patients. And it really sort of took off more after all of these trials came about, because we realized that we could be benefiting patients by having them have a delay in progression-free survival, because more and more drugs are coming out that could be game changers. So this is sort of a table that just puts basic data together, or the results together from all of those trials. And those trials looked at advanced ovarian cancer patients, essentially all who responded to platinum-based therapy, and then they were put on maintenance PARP inhibitor or maintenance PARP with bevacizumab or bevacizumab alone. So those were different trials for all of that. So the overall population response was in all of these trials, there was definitely advantage of about 5 to 6 months in the overall population. You know, you may say, well, that doesn't seem like a lot, but then when the data got sort of divided up, because that's all comers, that's all HRD positive patients and HRD negative patients. When they divided it up into like the BRCA mutated patients, here's where the game changer was. So SOLO-1 was the Lynparza alone trial, and you can see, I mean, there was almost a 42-month, so about 3.5-year advantage for the patients, okay, with respect to progression-free survival. Then in the PRIMA trial, this was the Zejula trial, this or the niraparib trial, this was almost a 10-month advantage or 11-month advantage. The payola one was the olaparib or Lynparza with bevacizumab trial that had 15-month advantage. And then the veliparib had about 13-month advantage. So we're talking about significant dent in this. And then when they further looked at like more subcategories, so this was the HR deficient patients with, you know, who were also BRCA mutated, including the BRCA mutated group. Again, the advantage stayed. The HR deficient but non-BRCA, so that other 25, 20 to 25% category, again, there was significant advantage of almost about 11 to 12 months. And then the advantage was lower or smaller in the HR proficient, the other 50% from that pie chart that you saw that were not HRD or they were HR proficient or what was deemed to be HR proficient group. And you can see there wasn't much difference in these two trials. And then there was about a 3-month advantage in the niraparib trial, and that did gain them FDA approval for the category of HR proficient patients. Now, these two trials were the bevacizumab trials, and what this shows is that there was about 27% decrease as well as 13% decrease in or advantage of overall survival progression-free survival in these patients who received bevacizumab as maintenance. And then there was a subsequent exploratory analysis that was done from the tumor specimen for one of these big trials that was done, GOG 218. And they did see that there was some benefit in patients who were HR proficient. So bevacizumab did benefit. There was a dent that was made in patients who didn't fall into the HRD category where PARP inhibitors work their magic. And then the latest data is on the third PARP inhibitor that's approved in US, and that's the rucaparib or Rubraca. And again, the data stood in this trial as well. It was called the Athena trial, and it again, the patients had progression-free survival advantage of about 11-12 months. And then also, and specifically in HRD positive patients, that advantage was almost 18 months, with a lesser advantage in the HR proficient pathway. So let's get into a little bit of the side effects of these drugs. So obviously these drugs are wonder drugs right now for us, for patients. However, they don't come without their side effects. Overall, PARP inhibitors are well tolerated. However, the most common side effects include nausea. Most commonly with Lynparza or olaparib, patients do experience significant nausea. And they, for some reason, it's kind of strange. Most of my patients, they will have nausea for the first 4 weeks, and then all of a sudden magically just goes away at the 4th week. We don't really understand why, but it seems like maybe the body just gets used to it. But yeah, that's what we're noticing. So most commonly, most patients will stop experiencing nausea after the first month. Initially, the olaparib, when it was approved, patients had to take, I think, about 12 tablets a day. They used to take 6 tablets in the morning, 6 tablets in the evening. And those, I mean, in my mind, I was like, well, that's enough to cause you nausea. But now they have changed it to, you just have to take 2 tablets in the morning, 2 in the afternoon, in the evening, and it still does cause the nausea until the 4 weeks are up. Patients do experience fatigue. There is significant fatigue that's real for these patients. I think it's also cumulative because patients, most patients have undergone surgery and then that upfront chemotherapy, and now, are undergoing treatment again. So further treatment. So fatigue is real. Patients can still experience some hematologic or bone marrow changes. So most commonly we'll see anemia, so red blood cells, and then platelets going down, thrombocytopenia. There's also an small but absolute increase in about 1 to 2% increase in MDS, which is myelodysplastic syndrome, or AML, acute myelogenous leukemia. So basically blood cancers. So there, these things are not without their risks. Blood cancers can occur also from routine chemotherapy as well. It's been seen with platinum agents, and probably slightly less than this, but still enough to warrant that hematologic monitoring, meaning patients, even after you're done with treatment or while you're going through treatment with oral drugs, these patients should be getting their blood test, the CBC counts done. This is sort of a conglomeration of all the study, some of the studies basically, which shows that the toxicities were pretty similar across the board through all the PARP inhibitors. Again, the nausea, anemia, fatigue, thrombocytopenia was common. The PAOLA-1 trial, which was the one with the olaparib and bevacizumab, high blood pressure was another one, because the bevacizumab is actually associated with high blood pressure as a side effect. And then these resulted, at least in the niraparib trial, almost 70 to 80% dose reductions and interruptions, and in general about 25 to 40% of times there is some dose reduction or dose interruption. So I always sort of reassure patients that, that in the trials as well, there, when I have to reduce their doses or interrupt doses, patients always worry, well, is this gonna, make my cancer come back? Well, the trials had all of that, and the patients still in general responded really, really well. So that's part of the protocol. It's part and parcel for this kind of treatment. And again, the MDS AML increased risk was seen across the board as well. Let's change gears, and we're going to talk about HRP, the homologous recombinant proficient pathway. So, those are not the significantly genomic unstable cancers. And in that, as if you remember that slide that I showed you with the niraparib, the first column, that was FDA approved. So niraparib is FDA approved in this group. following the chemotherapy, and so basically tumors that lack the BRCA mutation or are not HRD, and the progression-free survival advantage was about 3 months in those patients. Again, the patients do experience significant adverse events with respect to red blood cells, platelets, white counts going down. These toxicities have gone down because there was new data where we used to start everybody on 300 milligrams, and now it's been shown that you actually want to start certain patients with a lower weight or lower platelets to start with at a lower dose. And that did decrease the toxicities and more tolerance and our ability to be able to continue the treatment. However, there's still a significant discontinuation rate of this drug. Bevacizumab is the other one that I was talking about, those other side 2 trials that we were talking about. And though the bevacizumab is actually started during the chemotherapy, it's given with the chemotherapy, and we usually give it. So if the patient has an upfront surgery, we skip during the first 1 or 2 cycles, and then we started in the latter cycles, only because bevacizumab does prevent wound healing. So we want to let the patient heal from their surgery. But then subsequently, after they're done with their main chemotherapy, we continue bevacizumab as maintenance, and that is continued for up to 2 years. It's been shown that it may have more significant advantage in patients who are considered to be much higher risk, like the patients who were stage 4 disease, who had effusions in their lungs or had a lot of large volume ascites, or the fluid that's produced by the cancer cells inside the belly, or who had suboptimal resection, meaning they had disease that was more than 1 centimeter at the end of the surgery, or who were inoperable or stage 4. So basically much higher risk group, so even subcategory within the ovarian cancer, advanced stage ovarian cancer patients. It's been shown that the bevacizumab does improve both the progression-free survival and overall survival, almost a 10-month advantage in that. Having said that, the data is still murky enough that even from standard guidelines, it's one of the pathways can easily be that observation alone, where the patients can just choose that I don't want any more treatment. I'm done with my initial treatment. I want to just take my chance at this point because I don't feel that there's enough of an advantage. And so that's certainly a discussion to be had.
Dr. Garg,
yeah.
Do you mind if I interrupt with a few questions?
Go ahead.
Okay. First one, is genetic mutation of TP53 part of the HRD positive response group with PARP treatment? No,
it's not. No, it's not considered. No, it's a different pathway, and no, that's not considered to be part of that. Okay, and most ovarian cancers are going to be P53 mutated. So yeah, like over 90% will have P53 mutation. Yeah.
Okay, thank you. Next one. What is the lowest effective dosage of Lynparza? Is it 400 milligrams daily or 300? Thank you.
It is, I think the lowest we can go is 400 milligrams. So it starts out at 600, and the lowest we can go is 400. Yeah.
Okay.
Okay.
And I have one more.
Sure.
Is there anything new to help with post-cancer radiation treatment? I go for pelvic floor therapy after having 35 rounds of radiation plus 3 rounds of brace radiation internal. Tissue is still extremely thin and bleeds to the touch. Will Mona Lisa help? Bladder installation, medical cocktail, anything else?
So it just depends. That's sort of a one-off question. Obviously, that's not applicable to ovarian cancer, and radiation is not the most common thing that's utilized in ovarian cancer. But nonetheless, it depends on where you are from the treatment and how far away you are from the treatment, because you have to let the tissue heal. There are definitely some radiation changes that can be longer lasting. and really sort of depends on what sort of changes are happening in the tissue. Sometimes the hormonal therapy helps, sometimes dilator therapy helps, and lubrication therapy helps. Mona Lisa and the likes of Mona Lisa therapy that have not been tested, or there's no big data in radiated patients. So I definitely worry about that for our cancer patients. That data, I mean, that work needs to get done, because I think we're doing a disservice to our cancer patients for this, but we don't have any big data on it yet.
If you don't mind, I have two more that just came in.
Sure.
Regarding granulosa cell tumor of the ovary, what hormone inhibitors are recommended for maintenance of recurrent GCT in combination with letrozole?
In combination with letrozole?
That's
Well,
how
I think that's sort of again a one-off. I mean, letrozole itself, I usually have not used any other hormone therapy in combination with letrozole. I mean, the patients have to be menopausal to get letrozole, so both ovaries have to be removed or they have to be suppressed. The other, essentially, so the hormones that are active in granulosa cell tumors, like we look for estrogen positivity and progesterone positivity. So we're basically suppressing that pathway. So I don't usually utilize anything in combination with letrozole. There are studies that are happening in other low-grade tumors that we may extrapolate from, but at this point, no.
Okay, thank you. That's all I have at this time.
No problem. So we'll move on to surveillance. Obviously, once we sort of, get through all of this treatment, and it's intense and grueling. The whole reason I went into GYN oncology is because women like you who are so brave, and you come in, you get all of this tough treatment, and you still worry more about your families than yourself, and it's just very inspiring and moving. But we want to be watching and surveilling and making sure that the cancer doesn't come back, or if it does, then we try to catch it early. So the National Comprehensive Cancer Network guidelines for monitoring patients who have completed treatment, this is sort of the overall recommendation, which is that the patient should be getting office visits where we reevaluate the history. We're checking on patients' symptoms, anything that can be a red flag. We're doing a general physical and a pelvic examination to look for any nodules or any kind of tenderness that can be triggered. So this includes doing a speculum exam and a bimanual exam, both the vaginal exam and a rectovaginal exam. So if you haven't had a rectal exam, you definitely need to be having a rectal exam. My patients are always sort of surprised when they see me because I examine every patient the very first time I see them, and I do a rectal exam. So they're always sort of taken aback, but that is a comprehensive exam that needs to happen in all patients, because we can pick up disease that way. And this should happen every 2 to 4 months. In general, most of us utilize 3 months as the middle mark, and we do every 3 months for 2 years. And then we can space out. There are some GYN oncologists who will do every 3 months for another year, for the third year as well. But in general, most of us will space out to every 6 months from year 3 to 5, basically. So basically close follow-up for 5 years, and then annually after that. So once you get diagnosed with cancers, you don't really fall into that category where after a certain age, you don't get monitored, or you don't get pelvic exams and things like that. You basically will never fall into that category. So even after the close surveillance for cancer is done, you still need annual exams every year. The CA-125, which is cancer antigen CA-125, or other tumor markers that are done, it's sort of a controversial topic, but in US, the standard in general, we tend to check the tumor markers every visit, especially if the marker was elevated at the initial presentation. So basically, it's an individualized marker for that patient. There are About 50% of early ovarian cancer patients will not have elevated CA-125. And about maybe 10% of advanced stage ovarian cancer patients will not have elevated CA-125. So those patients don't fall into these category. Having said that, I have also seen patients, all of a sudden the CA-125 become a marker for these patients. So everybody sort of, if you go through across the country, people will have a different mindset and different, all clinicians will have a different recommendation, but in general, we tend to utilize CA-125 as a tumor marker that is monitored at each of these visits. So when you come every 3 months, the blood test is done every 6 months as well, and so on and so forth.
Dr. Garg,
Yeah,
if you don't mind, I have a few more questions for you.
sure.
What does X month advantage mean? Months advantage from what point in time?
It's from the end of the treatment. Yeah, so that's a great question. Yeah, it was actually a question that was asked in my board's exam. So, people are confused even as physicians, enough that it was asked in a board exam. But yes, basically at the, when all the treatment ends, so it's not from your surgery or the diagnosis, when all like the last chemotherapy was given, that's when we start counting the progression-free survival or overall survival. Okay, what else?
Thank you. How long should patients be on PARP inhibitors? 2 years, 3 years?
So that's the research, the trials in patients who had no disease, no evidence of disease at the end of the treatment and when they started the PARP inhibitor and again developed no evidence of disease. I followed the textbook, the research guidelines, research trials stopped giving PARP inhibitors at 2-year mark on those patients. Now, if there's any disease that's been stable, then there's no question we continue the PARP inhibitor, basically. But the patients, and that's always a very difficult conversation to be had because patients are very, you're attached to the PARP inhibitor at that point, but you don't realize that the PARP inhibitor is also making you feel bad. There are side effects that are ongoing with PARP inhibitor. And obviously there are risks that I just went over with the PARP inhibitor, including the blood cancer. So that's it's a conversation to be had, but in general, I pretty much recommend that the patients stop the therapy if they have no evidence of disease at the 2-year mark.
Okay,
yeah.
2 more. I was taken off rucaparib after 2 months due to peeling skin on hands and feet. I didn't see skin issues as a typical side effect, though. Is that common?
Yeah, it's not common. I mean, it can happen. I mean, there are a lot of sort of, much lower category, rare category side effects. But I don't, it's really hard for me to say how bad the peeling was, and if they tried like stopping and giving some topical therapy and then reducing the dose. So that could have been that could be a conversation to be had, especially if you fall in that HRD positive category where you can gain a lot of benefit from it, then it may be worth a conversation.
Okay, and one more. I was recently told by Northwestern Gynoc that a new study has shown that bilateral prophylactic and surveillance for BRCA patients have been shown to have the same survival results. Opinion?
So surveillance versus the surgery?
Yes, for a bilateral mastectomy for BRCA.
So bilateral mastectomy, I can't really comment on.
Okay.
But for bilateral like oophorectomy and salpingectomy, no. I mean, there is still significant advantage because you decrease the risk of cancer occurrence. So prophylactically, those guidelines have not changed.
Okay, thank you.
Yeah. Okay. So basically, as I've been sort of going through the surveillance, as I said, evaluation of women after adjuvant chemotherapy varies depending upon, clinician preference, and obviously also a dialogue between with the patient, including CT scans. So, we used to do imaging on ovarian cancer patients every 3 months on the dot, and then the data came out that, we're exposing these patients to radiation from CAT scans, and that's increasing the risk of complications and other cancers. So now, and we're not improving survival or prognosis for those patients. As a result, we don't just routinely utilize imaging. And I definitely sort of space it out. And most commonly, we utilize imaging when the patients are symptomatic, or we pick up something on the exam, or the CA-125 goes up. So those are the patients. And then in the patients where the CA-125 is not a biomarker for them, then those patients, we definitely utilize the imaging to be able to pick up if there's any recurrence. And usually when the CAT scan is done, it is done of the chest, abdomen, and pelvis, which are the most common areas where the cancer can come. And we also do those CAT scans with oral contrast and intravenous contrast. The oral contrast will light up all the intestinal stuff, so it helps with anatomy and location. And the IV intravenous contrast will light up the vessels and the ureters. And so it really helps with the imaging and the reading of the imaging. A little bit more detail about CA-125. So CA-125 levels are done, as I mentioned, at every visit during surveillance if these markers are elevated at the initial presentation. And the routine surveillance may result in earlier disease recurrence detection, meaning it's been shown even as CA-125s can slowly start creeping up even as early as 6 months prior to the disease actually being detected or being symptomatic. But it has been shown that even if we start treating the patients based on CA-125 that early on, it has not improved survival, and it has, without improving survival, but increasing the toxicity of therapy, basically. So it's, again, a discussion to be had, but most commonly we don't just routinely start treatment just based on CA-125, especially if we don't see disease or the patients are doing or feeling well. I'm going to just briefly talk about survivorship. This aligns with the question about the radiation stuff as well, but it's a topic that we are just starting to talk more about. We don't as a society, we haven't done a really good job of addressing this for our patients. We understand that the combination of aggressive surgery and chemotherapy and all of this after treatment has long-lasting side effects. And it does decrease the overall quality of life in our ovarian cancer survivors. So, most common short-term side effects include like neuropathy, numbness and tingling in your hands and feet. Patients often complain of dropping things, not being able to write anymore, or having, memory and concentration issues, sleeping issues. They're also very tired, low in energy. So these are like sort of the early side effects, but then, there's also long-term side effects. The neuropathy can last much longer and could even be irreversible. The chemo brain, as patients describe it, or memory dysfunction or concentration difficulty, that can last a little while longer as well. The fatigue could be ongoing. There's also a lot of depression, anxiety that's associated with this diagnosis. And every single time, the patients come to me, especially prior to their visits, they're just right at their visit, they're really, really nervous until I tell them their numbers look good or their exam is done and it looks good. Obviously, the patients experience loss of fertility when we take their, if they've undergone big surgery and we've removed their tubes and ovaries and uterus. They've in younger patients, they have experienced loss of fertility. There's definitely sexual dysfunction because now we've taken away hormones, and also anatomically things are different because of the surgery. So the patients, and then mentally as well, there could be some as a result of that sexual dysfunction. And menopause, taking away the hormones can cause vaginal tissue to have changes. There are hot flashes. There are so all of those changes can have effect on quality of life. And why I'm bringing this up is that we're recognizing this, and then you as a patient have to help us out as practitioners and raise these issues as well if we fail to, because sometimes we get very target-minded, narrow-minded. We're just focused on your cancer and we're not thinking about all of these other things that could be affecting your life. But I think if you do bring it up, I'd be surprised if anybody would dismiss it. But it's a matter of you bring, we, at least here in our institution, I'm starting a sexual health program for our ovarian cancer and other GYN cancer patients, where we are specifically addressing these issues. And we'll have a dedicated nurse practitioner who's going to, examine these patients and keep in touch with them on an ongoing basis and treat them actively. We're going to have pelvic physical therapists. We're going to have behavioral therapists, all of this, mind and body integration to help improve our patients' quality of life. And that's a program that we're starting here at City of Hope. There's definitely data on impact of lifestyle and intervention for survivors, healthy diet, maintaining a healthy body weight, physical activity, decreases depression, limiting alcohol intake, all of that has been definitely associated with improved quality of life in survivors. So I'm going to end there. Thank you very much. You guys were very attentive, and I'm happy to take any more questions.
Does anyone else have any questions from our online group? I think I've gotten everyone. If I did miss you, please let me know. If not, we don't have any more from our in-person audience here, but Dr. Garg, we just appreciate all of your information today. It is just so wonderful to have a partnership with City of Hope and to have access to such good quality, experienced gynocs and other professionals who are with us today. We just had one more question come in. If you have debulking surgery, chemo, should you be on maintenance meds?
So again, that depends on, that's a discussion, and it also depends on the tumor. If you have any BRCA mutation, or if you have HRD, if you fall on that HRD pathway, then absolutely you need to be on maintenance. And then the ones who are non-HRD and NED, then again, there are those three categories that you can fall in. You can have a discussion about being Zejula or niraparib therapy. You can be on bevacizumab if you got bevacizumab with the chemotherapy, or you can choose to just be on observation alone.
One more came through about PARP inhibitors. Mm-hmm.
Yes, so it has been shown that even after we stop, that's another reason. It's been shown that even in that Solo 1 trial, those patients did, those were Lynparza alone or olaparib alone patients, and they had no evidence of disease and they stopped the therapy at the 2-year mark. The median progression-free survival was still 56 months, which obviously is way beyond 2 years, right? So there's definitely, we think that there is some lasting effect of PARP inhibitors.
Just before we leave, Jennifer Waldorf, who is my partner in crime here, helping with this event. She and I have put the entire event together. I am so blessed to be in partnership with her and with City of Hope. And she'd like to say a few words to our online audience before we finish this morning.
Okay, no problem. Thank you.
Thank you very much. And thank you so much, Dr. Garg, for taking the time out of your, sounds like a very busy Saturday, starting with T-ball and onto a wonderful presentation. So thank you very, very much for being with us here today. I know our in-person audience and our virtual audience greatly appreciate it. So huge thank you to you. Very much appreciated.
You're very welcome. Thank you.
Thank you.
Thank you for inviting me.
Absolutely. And then very quickly, just to the virtual audience, I did share this with the in-person audience before. For anyone that is familiar with Cancer Treatment Centers of America, City of Hope joined forces last year with Cancer Treatment Centers of America. So we are now CTCA, former CTCA, is now part of one of the largest cancer-focused networks in the country. Our Chicago area presence includes our main hospital in Zion, Illinois, so northeastern Illinois. We also have outpatient clinics in Gurnee, And then here in downtown Chicago, we're actually on the top floor penthouse of our Chicago facility having this event today. So really it united two nationally renowned leaders in compassionate cancer care. Patients get great, we still have the same patient care experience that anyone who's treated at CTCA or knows someone that treated at CTCA, they're still receiving the same exact quality standard of care. Now we have access to even more clinical trials and research, physicians, expanded services and treatment options, and additional innovations. And City of Hope was founded in 1913. So just very proud to be part of a great organization. In addition to our Chicago presence, we also have hospitals in Atlanta, which is where Dr. Garg joined us from, and in Phoenix. And then City of Hope also has facilities out in Duarte, California, and Orange County, California. So more information, if you are interested, it can be found at cancercenter.com, including the CTCA City of Hope difference, bios of all of our physicians, including the wonderful Dr. Garg, who shared her expertise with us today. So thank you all. We are going to take a brief 10-minute break. And for those of you who joined us virtually, this was the virtual component of today's program. So we did record it. So we will be, Karen will be sharing that out following, but we are going now to jump off of the virtual presentation.
I'll take off.
Thank
you, everyone.
so much.